I too want to welcome all of you here today. I'm Lauren Leroy. I'm currently working as an advisor to private foundations, government agencies, nonprofits, and others that work in the health arena. But I was asked to moderate this panel, I assume today, because I was initially the deputy director working with Paul Ginsberg of the Physician Payment Review Commission, tried to follow in his big shoes when he left as executive director and was the first executive director of MedPAC. I'm very much looking forward to the conversation today and to the presentations we have before us. As Bob said, 25 years after the Medicare Fee Schedule was introduced, it's still the dominant form of payment for physician services. But it's under stress in its traditional role, and it's facing new demands as many alternative payment models in which physician compensation is based on it are being developed and implemented. PPRC developed its recommendations for the Medicare Fee Schedule in 1989. And later that year, the Congress passed legislation that enacted the parameters of the Medicare Fee Schedule, as well as provisions to protect beneficiaries and to attempt to restrain spending growth. As Bob said, one of the defining words behind the motivation for the Medicare Fee Schedule, or the defining concepts, was to rationalize physician payments by tying them to the resources required to deliver specific services. It was assumed at the same time that while this would lead to more equitable payments to physicians, that more was likely to be needed to try to control spending or to affect the volume of services. So further provisions, both targeting spending and providing information and tools to physicians to encourage more appropriate care, were also included in the legislation. Now, fast forward to today. We're still grappling with disparities in compensation between procedural specialties and primary care, with how to keep up with changes in medical practice when valuing procedures or evaluation and management services, with how to restrain volume and expenditures, and with how to transform healthcare delivery to improve quality and the appropriateness of care. One could argue that as we look to the development of alternative payment models, which will define physician payment in the future, that there's considerable continuity between the challenges that were faced when the Medicare Fee Schedule was enacted and current efforts to try to reform payment. And there's also much to be learned from the last 25 years of experience. Each year, the PPRC report to Congress began with a chapter called The Context for Reform. Anybody who was working at PPRC at the time probably cringes when they hear that, because it was always a challenging chapter to put together. But in some ways, I see this panel as performing a similar role for us today, providing historical context and discussing more recent developments that can both provide background and frame the topics for the sessions that follow during the day. We have 4 terrific speakers, so let me quickly introduce them so we can get on with the program. First, going back to 1989, we have Paul Ginsberg sitting here to my right, who is currently the director of the USC-Brookings Schaeffer Initiative for Health Policy. That is a mouthful, Paul, I have to say. But his true claim to fame for today was that he was the founding executive director for PPRC, and PPRC moved through the period that we'll be talking about today under his leadership. Next, we have Chip Kahn sitting next to Paul, President and CEO of the Federation of American Hospitals, but for today, drawing on his experience as the staff director for the Subcommittee on Health of the House Ways and Means Committee during the deliberations over the Medicare physician payment reform. Then, to try to move us through the fee schedule's implementation and on to the present, we have Barbara Levy, Vice President for Health Policy and Advocacy at the American Congress of Obstetrics and Gynecology and Obstetricians and Gynecologists. Let me get this right. And for 6 years, which I think is remarkable for any single human being, she chaired the American Medical Association's Relative Value Scale Update Committee, or the RUC, leaving that particular position in at the end of 2015. And finally, we have Mark Miller, the current executive director of MedPAC, whose work encompasses both addressing issues with the Medicare fee schedule and the development and implementation of alternative payment policies. So it really is a terrific group, and I'm going to hand it over to you, Paul.
Thanks so much, Lauren, for that introduction. And good. Nope, wrong way.
There you go.
Perfect. Okay, perfect. So, yeah, Bob and Lauren have filled you in on all the things that should have been said about the context, but I was not planning to say. So they've really contributed to my talk. Anyways, the initiative for the legislation that led to the Medicare Physician Fee Schedule really came from Congress. This was not something that came out of the administration. The administration was definitely engaged in the process, but in really places like the Senate Finance Committee, the Committee on Ways and Means, Committee on Energy and Commerce, members were talking about these issues a lot in the mid-1980s. And what was driving them was concerns about the imbalances in the fee structure that they were perceiving, or more likely, various stakeholders brought to their attention. And they were particularly focused on this distinction between procedures and visits. They were concerned that Medicare was paying relatively too little for visits and too much for procedures. Particularly in the Senate, there were serious concerns about the urban-rural dimension, about how much less Medicare was paying in rural areas than in urban areas. And this was done in an environment of deficit reduction. The 1980s was a time of almost annual omnibus budget reconciliation legislation designed to meet a target for deficit reduction. And what happened in 1984 is that finally hit physician payments in Medicare, where there was a freeze, I think, for a year. And there was no updates in physician fees in the Medicare program. And I think a lot of people started thinking, if we have such an imbalance in our relative payments, isn't the freeze or real pressure on rates going to make it particularly problematic for the services that are underpaid? Or if you look at the other side, would such constraints would this imbalance actually limit the potential to save money in this area, because you would quickly run up against real problems for the relatively underpaid services? The administration at the time was more concerned, but they were very concerned about excessive volume. And they would like to have made Medicare spending a more predictable part of the budget and get some control over not just prices, but overall spending. So the process. Basically, Congress issued a directive to the predecessor of CMS, HCFA, to fund a relative value study. That turned out to be the study by Bill Chow and his colleagues at Harvard, and it created the Physician Payment Review Commission, but gave it a strikingly specific mandate, basically saying, these are the issues we want recommendations on, this is what you should be working on. There was a key piece of preliminary legislation that was passed as part of the 1987 budget reconciliation process that, based on recommendations from the Commission, Congress named 13 important procedures as overvalued and mandated reductions in the Medicare payment for those procedures. I say this was key preliminary legislation. It was almost like a test vote, that if that could pass, it showed the receptivity throughout Congress for more sweeping reform in physician payments. So what were the major design issues in creating this payment system? Well, one thing I would describe it as, we didn't use those terms back then, but basically it was a science-based approach to set relative values. This was not an approach based on, well, how much more should a surgeon earn than a primary care physician. This was an attempt to use science to determine what the relative values should be. So it involved measurement of physician work and practice expenses. And the physician work involved time and also a concept called intensity. It was a very deliberate decision not to limit physician work to time. This may have been due to strongly held conceptual beliefs. It may also have been a political realism thing, that the magnitude of redistribution, if the fee schedule were strictly time-based, probably would have been far too large for the legislation to ever have been enacted. In a sense, what this science-based approach was doing was simulating a hypothetical market, a working market for physician services, which obviously did not exist at the time. So instead of taking the cues from the, at the time, dysfunctional physician services market, it really created a series of relative values as to what a hypothetical market would result in. There was no attempt to specify either in absolute terms or in relative terms what physician incomes should be, either overall or in different specialties. There was an attempt to address volume that Bob Berenson mentioned before. Congress called it volume performance standards. And I think the concept behind it, which did come for better or for worse out of the Physician Payment Review Commission, was to engage the leadership of the medical profession in addressing some of these volume issues. There was a lot of activity at the time of development of practice guidelines. Peer review was advancing. And I think there was pretty broad recognition about the tragedy of the commons problems. So this would not affect the incentives of individual physician practices for volume. So in a sense, it was a challenge, a broad challenge, an opportunity to the profession. And my sense is that SGR, which obviously is looked down upon very poorly today, was really an attempt that pushed that idea too hard. Another aspect of the reform was stringent limits on balance billing, which have not changed to date from where they came out of this legislation. This was a long-standing priority of the AARP, and also the balance billing limits reinforced the revised structure of fees. And finally, there was how are the physician work values and practice expenses to be updated? And a major priority of the American Medical Association, which did support this reform, was that they play a role as a convener of specialty societies to do these updates. So they envisioned the specialty societies working within the AMA rather than the specialty societies coming to CMS or Congress and lobbying. In a sense, I think what might have gotten lost in the process was that by working this out within the AMA, the staff at CMS did not perceive that it had a job to do, which it would have had to do if it was they were making the decisions based on the direct lobbying. So early experience with reform, there was a substantial shift in resources towards payment for visits and away from procedures. I'm often surprised when I talk to younger physicians that this surprises them, that they just view it as, oh yeah, they attempted to do something and it didn't work. But you know, the data published by researchers at HCFA at the time showed very substantial shifts in resources away from procedures towards visits, away from procedural specialists and surgeons, towards primary care and other specialties where much of their work involves visits with patients. In my perception, the shift was undone by an inadequate updating process over a period of 25 years. The volume performance standards, the attempt to address volume, did not blow up. It actually led to, increases above the default in some years and below the default in other years. That didn't happen until the SGR, in a sense, made it a much more stringent policy. What also surprised people a lot is the degree to which private insurers adopted the Medicare relative value scale in their own payments. And of course, they chose their own conversion factor. But this actually greatly facilitated for them negotiation of payment rates with physicians. It was one number they could discuss. What percentage of Medicare is the payment going to be? Medicaid programs also adopted this very readily, but that was not a surprise. And I would say that over the years, there has been fairly limited or very little congressional micromanagement of this. This doesn't mean that Congress isn't quite concerned today about what they see as significant payment distortions, and Congress has taken some steps to reduce extreme overpayments, such as advanced imaging, which they did many years, and in recent years have issued directives to CMS to more vigorously address current distortions, to put more resources into updating the relative values, but the response has not been very good. Thank you very much.
Good morning, and I want to express my appreciation to Paul for asking me to come this morning. I appreciate the introduction, and my purpose today, my assignment, is to speak about the genesis of the legislation of the Medicare Physician Payment Reform. I'd like to qualify my remarks first by stressing that I will be commenting looking back through the prism of time. Obviously, a lot has happened since the 1980s, and stress that my observations are impressionistic, and my apologies to anyone who questions my, I'm sure, revisionism in terms of telling the story. I'll try to provide some color as we go through my story. Let me also say that at the time of the sort of 86 to, for me it was to 93 period, I was the Minority Health Counsel on the Ways and Means Committee, primarily working for Bill Gradison, who was the ranking member on the Health Subcommittee. Pete Stark obviously was the chairman on Ways and Means Health Subcommittee. And then in my next iteration on Capitol Hill, I was staff director, and you can partly blame the SGR and the spread, the final spread of prospective payment, which Bob talked about on me, for better or worse. I will answer that. We'll see how you feel when I finish about whether it's better or worse. So how did this all get started? Well, I think just without going into too much history, I think the defeat of Carter cost containment began a process of reexamination. I didn't work for hospitals then, but hospitals got away with a voluntary effort and beat Carter cost containment. And then everybody's hands were up in the air because there was still a problem. So when we got to the period of Reagan, we had the advent away from trying to change the whole system and a focus on Medicare. Primarily from, I think, the administration, it was concerned about cost, but there also was, I think, a worry about the value proposition and quality. And so that began a process that I think surprised everyone in 1983. I won't go, there was some earlier legislation that led to the 83 Social Security Act amendments, whose last provisions were the DRG provisions. Actually, those provisions were put last in the bill because the Ways and Means Committee and Finance Committee staff working on them thought they would be chopped off in conference, but they weren't, and I think that began a process. Physician payment reform's roots are in the DRG system, even though obviously the DRG system itself is a much different system. But I think that created sort of the passage of DRGs created an energy, and we can call it either an aspiration, I think more now, looking in retrospect, a conceit, that we could drive change through Medicare, and that we could use new methodologies to use the economics of payment to change provider and clinician behavior. That's what it was all about, and that's what, in a sense, DRGs proved. And frankly, of all the programs in prospective payment, maybe the DRGs are the only one that we could look at, over how many years and say, well, at least that worked. So what came out of this was what I'll call a reform imperative. And in some cases, I think it was almost anything that was a reform to the policy nix was a good thing to do. A couple of other things happened, too, that I think are very important. PROPAC, the Prospective Payment Assessment Commission, came out of the DRG legislation. Bob Hoyer, a Democratic Finance Committee staffer, didn't trust the Reagan administration and thought that Congress needed its own policy advisory group. And in this case, it was just to advise them on the process of the development of the DRGs over time. But there's a direct link between that and in COBRA 1985, when Congress in its wisdom came back and said, PROPAC is working so well with Stuart Altman and Don Young and everyone over there, that we now want to invent another agency, this was the Physician Payment Review Commission, that would actually help us implement new policy, not just go back and oversee current policy. So that's where PPRC came from. And then, so three things came together. Paul really described them. One was HCFA's effort to fund Bill Chow and the development of the resource-based value scale. The other was all the work that was described with PPRC. And then the other were the facts on the ground, which Paul referred to, 14% Part B growth, and a lack of a sense of balance in the program, not enough emphasis on primary care, and maybe too much incentive for procedures. In a sense, we didn't call it coordination and integration, and somewhat different maybe, but really basically the same issues we deal with today. So that drove the imperative for this policy development that led to the process that Paul and Bob began to describe this morning. In the 1989 bill, things got going. All the groundwork was done by PPRC for the RBRVS aspect of it. But as Paul described, what's Medicare spending, whether it's Part A or Part B or healthcare spending generally, it's price times volume. I don't want to say that PPRC did work on the volume side, but clearly here I think the central character is Pete Stark and his staff, because Pete made sure there was sort of this synergy between or connection at the hip between his staff and Phil Lee and Paul and Lauren. And so in those days, and I don't think it's as true today with MedPAC, not that there isn't communication between the staff and the commission. I think back then the commissions worked very, very closely with staff. And so I would say that whereas with the RBRVS, there was a tremendous amount of energy from many quarters on the issue of volume. I think at least at the get-go, it was Pete Stark, Pete Stark, and Pete Stark. He wanted expenditure targets. And on the one hand, I think there was a lot of flowery notions about doctors being able to get together and do the right thing. But I think from Stark's standpoint, he just wanted to make sure they didn't do too much because he was worried about the aspects of constraining fees through the RBRVS. So in the action, you had the Energy and Commerce Committee in the House. As you know, we have split jurisdiction in the House between, on Part B, between Energy and Commerce and Ways and Means. They did the straight RBRVS and physician reform. We at Ways and Means did RBRVS plus expenditure targets. And the Finance Committee, in its wisdom, did RBRVS and I'd say expenditure targets, or they called them something different, light. And then we went to conference. All these provisions were in the bill that went to conference. And you know, the RBRVS was fairly simple. It was fairly common between the bills and had been staffed by PPRC. So that was the easy part of it. There was controversy over whether or not there would be expenditure targets in the final bill. I think at one point Mr. Waxman, who was Health Subcommittee Chairman on the Energy and Commerce Committee, and his staff thought there would at least be expenditure targets light, if they would even be in there. And there was an agreement to that. And then, in the middle of the night, when the big reconciliation bill was being finally considered, Mr. Rostenkowski got together with Senator Benson, Chairman of the Finance Committee, and some magic happened. The more stringent volume performance standards were adopted. And I'll never forget, sort of the morning after, I went over to the Leg Council for the final drafting of the legislation before it was going to go to the floor. And, you know, I think in my experience, I'd rarely seen health staffers cry. And I won't mention any names. But when I went over there were all these Energy and Commerce, there was actually more than one, Energy and Commerce staffers literally crying because they thought that the Ways and Means Committee, and they didn't blame me because I was just a Republican on Ways and Means, so they thought I was blameless. You know, they looked at me and said, "Do you know what they've done?" I said, "No, what have they done?" They said, "Wendell Primus got together with, you know, and pushed Rosti, and they did this." So we got the more stringent targets. More about that later because I had more fun with that in 1997. So that was the creation of the bill, and it went forward. And as Paul described, I think the MVPS either worked well or was very soft and did not have much bang over the years. After 92 and implementation, you still had relatively large growth in Part B. And then that gets, and I'll conclude with this, to the end of the story, which I guess is maybe the beginning of the real tragedy of physician payment reform. And that was when I was a staff director on the Health Subcommittee, and we had a very stringent mandate about how much money we had to save in BBA 97. I won't get into the details of BBA 95, but most of the roots of 97 were in 95, where we had really big targets to meet. And so that was where the sustainable growth rates came from. A combination of, we still had tremendous growth in Part B that was, in quotes, as we always said, unsustainable. And two, the need for budget constraint, and that led to SGR, and we all know what happened after that. And fortunately, we now have MACRA and no longer have SGR. But clearly, at least from my perspective, whatever it was supposed to achieve on the constraint side, that didn't work out very well. And I think we heard from Paul that on the RBRVS side, there may have been some effect early on, but it was a difficult thing to hold, you know, over 25 years. So with that, I'll pass the baton.
Great. So on the AMA side, we were looking at all of this and saying, who's going to adjudicate all of this, and how are we going to decide who does what and how and why? And in 1992, the AMA came out with the RBRVS Update Committee. Just a little background on coding so you understand what the background for all of this is. We basically have code sets that define where these RVUs are allocated. And there are procedural codes, the CPT codes, and there are then justification codes, ICD-9 and now ICD-10, that describe why you did what you did. But the RVUs are assigned to codes. There are about 7,000 codes in CPT. That's a little bit of work to do to decide how you're going to allocate across 7,000 codes. So the AMA convened an expert panel. This was never supposed to be a panel equally representing the world. It was supposed to be a panel of specialty societies that could, in a zero-sum game, sit around a table, and some would win and some would lose. But that using their expertise in medicine and the science of medicine could adjudicate the allocation of RVUs. That is not a straightforward task. Intensity is in the eye of the beholder. And we learned very early that some surgical specialties would come and sit before the table and talk about families and people dying and, you know, all of those things, and others would come in and talk about, but this demented patient sitting in front of me and it's terrible and I have to deal with the family. And the science of the psychology of intensity was quite interesting. And I'll just leave it at that. I have survived 6 years as chair of the RUC. Maybe we became a little bit more collaborative, but we also came up with some systems that would help us look at those things and make some sense out of it. So the RUC has been making recommendations since 1992. The data are collected by the specialty societies, both for time and for some measures of intensity, but then they are presented to this committee of the whole and have to be defended. And that was really the new thing that the RUC brought to this process, was a defense of the proposed RVUs for work around a table of peers and getting to some consensus by the end of a meeting, which was not all that easy to do. The RUC process has over 100 specialty societies with advisors that are there. The voting members of the RUC are now 31, started out at 29. There are also representatives for ancillary medical professions that are represented in the fee schedule. But as we've already been talking about, there are some real problems with the RBRVS, and it is piecework. And it is payment for volume. And whether that's payment for how many patients you can rush into your office all day or payment for how many open heart surgeries you can do, it is still piecework. And there's some other sort of interesting things that I've always found from a policy standpoint to be very disturbing. So in RBRVS, we pay a physician 1 day out of training exactly the same as we pay someone with 30 years of experience and proven outcomes. How does that, there is no other profession about which I'm aware where the fees are the same. Whether professionals don't have to demonstrate some outcome to prove their value. Reputation, experience, collaboration with others. So it's kind of interesting. But also what's happened over the last many years since 1992 is a real change in industry. We have all kinds of ways of managing things now that we didn't have before. We have pharma pushing medications that add to the cost in the Part B system because some of those drugs are in Part B. We have a lot of equipment and changes. We've gone from, cardiac surgery to interventional cardiology, and trying to take all those new codes and assign RVUs to them has been a real challenge. Assigning those relative values, particularly when things start out as very difficult because they're new, and how do we look at them 5 years later, 10 years later, and adjust the values for those things. So a couple things that have happened over the years with the RUC. We've added seats for geriatrics and for primary care to make sure that that voice is well heard. And there's a lot more transparency to the process, which I think has also been really important. One of the big hazards with RBRVS was the mandated update, the 5-year review. And for the first 3 5-year reviews, that at that time HCFA and then CMS relied upon public comment to bring forward codes that were potentially misvalued. So occasionally a private payer would recognize that a set of services was overvalued, but in general, what would medical specialty societies do? They would fight for codes that were undervalued in the system, but no specialty society would make a comment to CMS to say, please reduce the payment for me and my members for this particular code. Because the specialty societies were paying to play. They were paying to send people to the RUC. So over the first 3 5-year reviews, what we saw was escalating costs and a redistribution, as Dr. Ginsburg said, of some of those dollars back into the interventional specialties. Just after the 3rd 5-year review, and having listened to Mr. Miller and a lot of commentary, the House of Medicine got together and said, okay, we need to do this. And the RUC took on the task of identifying potentially misvalued services. A huge undertaking, a very, very difficult vote around the RUC. I was chair at the time. Bill Rich had set it up for me, so he'd done a great job. But the RUC took on that task, and the AMA staff put together screens so that we could begin to very fairly and reasonably look at potentially misvalued services. And over the years, 1,700 out of the 7,000 services have been assessed as potentially misvalued. 1,300 of them have been reviewed, and it has redistributed back about $38 billion in Medicare. So it was a contentious process. It continues to be a difficult process. The specialty societies, and I represent one, are not happy about having to resurvey codes that are nicely paid and take cuts. But that's what's been happening over many years. The other thing that's sort of an unintended consequence of RBRVS is on the practice expense side, it's the difference in payment between the same procedure performed in a facility and a non-facility. And that just highlights for you the difference in a new patient complex service when provided in a physician office at about $200 versus in a hospital or a hospital-employed physician who is same physician, same practice. Last year I was private practice. This year my practice is owned by a hospital, and the payment is $130 more for the same service. Now, the physician payment is no different. The work RVU is the same. What's different is the practice expense. And that's an unintended consequence of RBRVS. There were reasons for all of this, but as we've seen consolidation and we've seen the number of physicians become employed by hospital systems and large systems, and this is just a graph to show you that somewhere around 60-70% of physicians, and my understanding from the College of Physicians is up to 80% of newly trained internal medicine physicians are hospital employed or employed by large systems. That adds a cost to the system that is not allocated to the physician. So it's an unintended consequence of the demarcation between practice expense and work RVUs. So where are we? I think that RBRVS is, the RUC has done a lot to update the process over the last 6 to 8 years. There's been a lot of change and reallocation, and the AMA RUC and the specialty societies have taken on the burden of revisiting codes and revaluing services, bundling codes together. It's been a big burden for CPT as well, because one of the screens is things that you always do at the same time together, and bundling those together and taking account of the resource allocation, which there's overlap when things are done at the same time. So I don't need to show you this slide that we're spending far more money in the U.S. than we can afford. We're spending 4 times what the next highest country spends, and our outcomes are not better. But I'm not sure that RBRVS is dead. I'm not sure that the input from the physician community should be lost. I do think that we have to go far beyond fee for volume and go to a value-based system. But even within a value-based system, we have to adjudicate in some way how we pay for providers. And so I do think that there is a role for an organization like the RUC where the specialties can sit around together and work on those things. I think current resources may or may not be applicable to all of the advanced payment models that we're going to look at. But certainly continuing to adjust things over time is important. I think that we need to be flexible and understand that some innovations will be very valuable and some will not. But we live in a culture where our communities, our patients want more and more, and they want the latest and greatest. And that's far different. We don't have systems in place in this country to put the brakes on some of those things. We don't have a NICE here in the U.S. that tells us, wait, we're not going to pay for those things until they're of proven value. So those new technologies is a real challenge for us and something that RBRVS really can't address entirely. So I think, is there a future for something like the RUC? The answer is yes. If you want to have a venue where the physicians and the providers are around the table talking about critical payment systems, I think it's yes, because I think we need the voice and we need the support and we need the enthusiasm of the provider community to deliver better care at lower cost. And the last thing is something that's an unintended consequence, but the RUC and CPT panels have really grown a lot of physician leaders who deeply understand these things. There are very few of us. And we are really needed in order to help inform the process as it goes forward.
Okay, I'd like to thank Paul and whoever else was involved in asking me here. I know it's always a risk, so I appreciate you taking that risk. And Lauren and Katie for giving me guidance on what I should say and do. And I guess to any young people in the audience who are listening to this and thinking this sounds really cool and they want to dedicate their career to it, don't do it, it'll break you. I used to be a really happy guy. No, I'm not. Okay, all right, but seriously. So all this has been said. I thought I had some really interesting comments that everybody would go, oh, really? But everybody knew all this. So the intent of the fee schedule was to reverse the charge-based mechanism that physicians were being paid. Physicians very quickly figured out if they raised their charges, they got paid more, and that was a bit of an issue. The second thing that it was intended to do was to correct this imbalance that had resulted through, the charging practices where the procedural side and the cognitive side, or the procedural and the primary care side of payments were thought to be distorted. People also thought that urban and rural were off, which Paul said. And then as the process started to get cranked up, people said that, we should also be looking at volume controls. I think the fee schedule has probably failed on 2 counts. 1, it has not rectified that balance. And 2, it never really achieved any volume control in any consistent way that I think could be documented very well. The imbalance continues under the volume controls. I think the imbalance was actually accelerated because of when you kind of added to the process that was going on in the RUC, which Barbara went through, and I thought did a very good job to describing that, as well as the notion of generating new codes. The procedural side of the fee schedule had the ability to do that. A new code would be created, it would get a high value, but then it wouldn't necessarily be reevaluated over time as efficiencies were gained. Procedurals had greater opportunity to generate volume, and of course, if there was any penalty to that, it was borne by all physicians and not, the physicians necessarily who were directly benefiting from it. We believe that there continues to be an imbalance in the fee schedule. With the Urban Institute, Steve Zuckerman over here, we have documented regularly that there are sort of hourly and net compensation differences across the specialties that are quite large. And also with the University of Minnesota on a very much a proof of concept type of basis, a very small scale. But I also know other people have done this. Again, the Urban Institute folks, Bob and Steve, and some RAND folks have done this. Been able to track real differences between the time physicians actually work versus the time that is assumed in the service. And we believe that there is a distortion throughout the fee schedule, that the fee schedule assumes more time than it takes to deliver a service, but it is highly distorted at the procedural side of the fee schedule. So the Commission has made a number of recommendations, and what I'm going to do now is just kind of go through some of those recommendations to try and address the process and this imbalance. I do want to say there is a huge, change in physician payment, which is MACRA, MIPS, and APMs. And I have things that I could say about that, but I think what we'll try and do is do that on question. I was asked to talk about this portion of the fee schedule. But if anybody wants to get into that, we can get into that too. Okay, so I was going to talk a bit about our views on the RUC process. Barbara did a very stand-up job in talking about the fact that it was creating distortions and it didn't work from the Commission's point of view very well, and she did a very good job in sort of describing who's going to step forward and say, actually, I think this isn't priced right, I want you to take it down. So about a decade ago, we were doing analysis, again, this time was with the Urban Institute, that was showing that the recommendations that were coming out of the RUC were to increase, very few decreases, and CMS was just simply accepting those recommendations. Change as a result of the attention and as a result of the tension between the RUC and MedPAC, the RUC has gone through changes, and again, Barbara went through those. We do believe there is a role for the RUC, but the RUC should be advisory, that the responsibility for the fee schedule very much lies with the Secretary of HHS and should be managed by HHS. And in fact, recently there was a proposed rule that said HHS would defer 100% to the RUC recommendations, and we very strongly said that that's the wrong direction to be going in. We made a recommendation to actually create an executive branch advisory group for the Secretary, comprised of physicians and nurses who don't have a direct financial relationship with the fee schedule, to both help identify where distortions occur and to review the recommendations that come across the transom from the RUC. We've also made a recommendation, and this is actually the roots for this, and I had even forgotten it until it was mentioned. The roots of this go all the way back to the legislation of identifying overpriced procedures. We said that there should be a 5-year period in which the Secretary identifies 1% of overpriced procedures each year and then reprograms those dollars, because we expect to find them on the procedural side of the fee schedule, to the cognitive or to the primary care side. I'm using the kind of 2010 ACA primary care definition, which we can take on question. The Congress actually took up something like that. They did a smaller amount over a shorter period of time, but our recommendation still is out there, and we feel that there's probably more that needs to be done there. Another recommendation we made was just to have a direct 10% add-on to primary care services, again, using the same definition that I've been using throughout here. And again, to reprogram dollars from the procedural side of the fee schedule and put it over on the primary care side. Congress did, in fact, pursue that. They did not do the reprogramming point. They spent new dollars, or deficit finance dollars, and financed the add-on, but that add-on has since expired. We've made another recommendation that there should be a primary care add-on, but we made one change in that, and I think there's a structural point that I want to make here. We said that the add-on should go to the primary care physician, using the definition that I've been using right along, but that the payment should be on a per person or per patient basis rather than a per service basis. And so the idea is to give the primary care physician some flexibility in terms of coordinating care, managing things by phone or email so that they don't have to get that revenue entirely through a visit. And some of the underlying thought behind that is that the Commission is starting to think that maybe the fee schedule is not well designed as it relates to primary care types of services, but maybe well designed for more procedural types of things. And so that thought is embedded in that recommendation. The last recommendation that I'll mention is that we think that there should be a different process for collecting data to determine what is overpriced in the fee schedule. So what we've said is that, again, this pivots off what I said a few minutes ago, where you can do analyses that suggest very strongly that the time a physician actually works versus the time that's assumed in the fee schedule. Sorry, this is a scientific, I don't have my slides, so. That the time in the fee schedule is generally higher than the time worked by the physician. And so the recommendation goes to this, which is CMS should identify standing practices that it collects and pay those practices in order to collect data from them on 2 data points, or 2 or 3 data points. The time the physician works, the services provided, which services are provided, and the volume of those services. And then you can use regression analysis, and it will point to the services where the time distortion is quite high. And then either the secretary could administratively choose to take the value of those services down, or ship that information to the RUC and say, we believe these services are overpriced, please consider them, that type of thing. So that's what I have by way of comments, and I'm going to stop, except I'm going to mention the other thing that Barbara brought up was the difference in getting paid for the same service, a couple $100 difference in the hospital setting versus the physician's office setting. I won't say anything more about it other than to say we've also made some recommendations there if anybody would like to talk about those. But then Chip is going to have something to say about it. And since I can't get back to my seat, I'm just going to go out for a
bit. Thanks very much, Mark, and to all of you. Before we open it up for questions, I want to start by giving the various panelists an opportunity to react to what they've heard, or if there was something you now realize you absolutely forgot to mention, to bring it up.
So let me just throw out something that's even much more difficult for us to think about, and that's market forces. But when we look at time, we're looking at time per procedure. We're not looking at on-call time or responsibility. So if there is 1 or 2, let's say there are 2 neurosurgeons in a community who are responsible for the entire hospital all the time, versus we have hospitalists and primary care docs who get to choose their hours to some extent, and I'm not downplaying the on-call, but we do have an issue with how many years of training, what's the opportunity cost for that level of training, and then what's the responsibility for some of those higher paid specialties, and how are we going to account for that in our, if we get scientifically down to the minute of how many minutes a procedure takes. And we don't count non-face-to-face time. So we don't count the phone calls from the ICU all night. we don't count some of those things, how are we going to bring that into our system?
Yeah, I'd just like to say one surprising outcome of this for me was that post 1983, private insurance companies generally did not adopt the DRGs. They got value, I think, from the effect of the DRGs on length of stay, but they stayed with per diems and negotiated those over time. Whereas on the physician side, there was a lot more adoption of the Medicare. They might have had a different multiplier, but a lot more adoption of the Medicare fee schedule. So I think the Medicare fee schedule, in some ways, in terms of the total system, has had a very large impact way beyond Medicare. Now, you could argue DRGs have too, but as a system, it didn't get adopted. So I think that's also noteworthy that as much as we lament it, it is a fundamental in the way both the private sector operates generally, because we can kid ourselves about all the wonderful alternatives there are out there. We still are basically a fee-for-service system.
Yeah, the comments that Barbara Levy and Chip Kahn made gave me an idea. Barbara said market forces. And I just wanted to point out that when we go beyond Medicare into private payers, another thing that is driving the relative values away from what science would call for is the fact that many procedural specialists have more market power because of the practices they're in. They tend to be, a larger part of the pool in that community. And research I've done on this shows that there, a very significant pattern of divergence from the Medicare pattern with private payers.
I found it interesting, one comment that you made, Barbara, about the fact that the current relative values may or may not reflect the appropriate allocations of resources and practice expenses for new models of practice, team-based models. And I wonder if you can elaborate a little bit on that, and whether others can respond or sort of react to the implications of that observation going forward in terms of how we're going to address that, given the problems that we've had to date, even trying to keep the relative value scale as it is now updated.
Sure. I mean, one of the issues is with, let's talk about care coordination. That requires clinical staff and staff that would not be allocated to individual CPT codes. So part of the issue is that we need to create new codes that describe work in an advanced payment model. And the RUC and CPT are working together to do those things. Several years ago, probably 10 at this point, with Medical Home, there was an effort to establish a prospective payment system for primary care medical home. And there was a large expenditure by CMS to a contractor to try to price that unsuccessfully. The RUC was able to do it, but it took a lot of work. So I do think that there are a lot of services that practices have always done, ancillary to RBRVS, care coordination, phone calls, non-face-to-face, trying to manage patients to keep them out of the hospital, to really reduce the total cost of care, that need to be accounted for in some way. And we need either new codes or new systems or a totally per patient per month payment system to be able to account for all of that, but we need to know what the elements are to get the right number.
Any reactions, Mark?
Well, I may not follow entirely what the question is, but to what you were saying at the end, of what you ticked through, I would probably not urge us to go in and start trying to find codes as opposed to more of your PMPM idea at the end, and say, if you're going to make a payment, then let the clinicians figure out within that the best way to organize their time and their structure, knowing that they have some kind of payment boundaries.
Yeah, the only reason to create codes is to agree among us what the carve-outs are. So PMPM as a universal, but everybody's always going to want, yes, but there's a carve-out for cancer, there's a carve-out for this or that. So I think there's some purpose in crafting, for example, would the PMPM be the same for a 65-year-old with very few underlying conditions versus an 85-year-old geriatric demented patient? So
the way I think about that is, and again, depending on what size unit and all of that, and so there's a lot of things here that are being assumed, I'd say yes, I agree with you that you might adjust the PMPM on the basis of the complexity of the patient, the condition of the patient. But what I think starts happening, and this happens a lot when you get into the kind of physician and physician fee schedule world, is your carve-out comment. Each of them steps forward and says, yeah, I'm into this, but I'm special and I need this. And then, when you have, hundreds of specialties and thousands of services, I mean, look at the quality measurement process right now and where MIPS stands in that. And it is really a product of everybody saying, you have to measure my specific thing at, I do a left-handed surgery only, and this is what you have to measure. And I think as long as both the payment and quality kind of drive down those types of paths, we will constantly be in these conversations. And I tend to think of it as going in the other direction and get less definitive, but put more of the responsibility in the hands of the clinician and say, here it is, manage it.
So I think that works if we're employed by large systems and the systems can take care of all of those things. I think it's more problematic in non-urban settings where you have individuals who are unable to do the total care of a patient. And I'm not disagreeing with you, because I think from a policy standpoint, that's where it needs to be, at a much, much higher level than it is. And I think there's much more resource utilization in urban settings where there are way too many specialists and too many consultations and too many things going on. But I do think we need to have some agreement on what that PMPM payment covers and what it doesn't. And to the extent that we have that agreement, that would be some sort of a code or some sort of a way of reporting what it is we're doing.
Chip, back in 1989, were there some in Congress who had different ideas that were put out on the table that you think would be instructive today for how to deal with spending or with the differentials among different specialties in terms of payments and the values for their services, or did most line up behind the Medicare fee schedule pretty quickly?
I'm glad you asked that question. I mentioned this sort of notion I have, which is the reform imperative. And I think probably 99% of the policymakers, the staff, and the advisors to Congress in the 89 Act, which was sort of the culmination of all the work that's been described, thought we needed to make the big change because we had the methodology. Bill Chow had done all this work. I believe it was on Medicaid in Massachusetts or wherever it was. And this is what we have to do. And I would assert that, and we suffered from this all the way, this disease, even in 97, was because the methodology was actually, in 97 it was worse because there we didn't even have methodologies. We just put language in there saying we've got to go to prospective payment for home health and some other things to sort of clear out all the areas that didn't have a methodology. And I think there was this notion to drive, which in retrospect, and I guess I am sort of conservative in that way, I wonder whether if we had made just minor adjustments to the existing reasonable and customary, whether we could have avoided a lot of history. And there were, myself and two other people that will go unnamed, who pled with members to think, well, gee, do we really need to do this? Can't we just, if this is really all about the imbalances, then we've been arbitrary in other things. Why can't we just be arbitrary in some of these codes and then see how it plays out, rather than moving to an entire system which is based on these RVUs that are still conversational. And any real research on this is almost impossible, because time and motion studies. And actually it's a moving crap game, because what a physician does one day with a procedure may not be what they do 6 months later, because even though they may not change completely, they're constantly evolving. So the time and motion, one day is not necessarily relevant 24 months later. So we questioned just the whole notion, but frankly, no one listened. So.
Actually,
let's see if you're going to say what I was going to say.
I remember that Bill Roper, when he was administrator of HICFA at the time, was very vocal about not wanting to put the energy into the fee schedule because the solution for Medicare was capitation. And I was always baffled when he would say that, because I didn't think he had a capitation proposal in his back pocket. And 25 years later, what have we done about capitation? Well, we do have accountable care organizations which do use concepts from capitation, but it's entirely based on the fee schedule. And I guess this is later in the afternoon. To the degree that the fee schedule is distorted, it could be a problem for ACOs.
This is an interesting question, because I now that you bring it up, I do remember Bill's arguments at the time. And I think the same thing happened in ACA, because with the focus was on ACOs and that notion, and not on bundling. And I would argue that in retrospect, it would have been better for Medicare to spend its time, and not sure all my employers would think about it this way, but they should have focused on the bundling side, and then and not spend all this energy on this unproven concept, which I think, frankly, if you're going to do managed care, let's do managed care. I think, with respect to the Democrats in the room, I think Democrats tend to be allergic to insurance companies, and they wanted this thing called ACO to do what supposedly insurance companies are supposed to do if they have any value proposition. Maybe they're not doing it, but I guess and actually going back to Bill's, I forgot that Bill Roper had said that, and maybe if we had put more energy into capitation back then, we would have had a different future. But it is what it is.
Let me open it up to the audience. Do we have microphones or how? Okay. Question right here.
I'm Dr. Caroline Poplin. I'm a primary care physician and an attorney and a columnist for MedPage, but not an economist. My understanding is that in Economics 101, if you pay too much for something, you will get too much of it. And if you pay nothing for something, like no money for telephone calls, no money to talk to the family, you will get not enough of it. And I don't understand why you don't incorporate this. If you think we're doing too many knee arthroscopies or back surgeries, you need to reduce the price. And people will not spend an extra 4 years learning how to do it if it doesn't make them that much more money.
Yeah, I can answer that because at the time that this legislation was contemplated, those arguments were made very strongly. In a sense, what might have motivated members of Congress was issue about, fairness to different stakeholders, but it was very visible, and a lot of it came from the commission about, this is distorting, this is making fee-for-service worse. So it is garnering more procedures that we already have too many of, and that still holds, as you say. And I'm convinced that the Medicare fee schedule, with its restructuring of payment, helped on that dimension. And to the degree that it has not been maintained, the issue is with us again.
Yes.
My question relates to possible unintended or intended consequences. You are all too young to be receiving explanations of benefits for office visits to physicians under Medicare Part B. If you received those, you would see that Schaeffer Urban Hospital Primary Care might bill something at $900. But its Medicare schedule is a reimbursement schedule. So then you will see that Medicare is reimbursing Schaeffer Urban Primary Care at $150, and that Schaeffer Care agrees to forego the other $750, if you follow my example. So they're billing at X rate. They're being reimbursed by Medicare Part B at a significantly lower rate. So my question is it the uninsured that are actually paying the $900 rate? And does that effectively mean that the uninsured are subsidizing the Medicare Part B? So point out the flaws in that. Thank you.
So I'll answer from a private practice standpoint, having dealt with 650 different insurance companies to manage my patient population. The reason for that disconnect to some extent is that the private insurers, some of them are still paying discounted fee for service. And so people will pick a number and get paid a certain percentage of it by Blue Cross Blue Shield, for example, where they might not from Medicare. But you're absolutely right that the people who pay that outrageous full price are the people who are uninsured, the people who have sometimes large deductibles or contracts with their third-party payers that allow for balance billing, or there's a practice that, for example, doesn't have a contract with Blue Cross Blue Shield. So I will hand you a bill, you can send it in and get paid from Blue Cross Blue Shield, but you owe me the difference, the balance bill. So yes, major problem.
So in the hospital, the private payers generally, in the outpatient context as well as the in, pay more that they have negotiated than Medicare or Medicaid does. And the uninsured person, at least in the hospitals that I work for, are generally offered a discount and generally pay nothing. So the uninsured person in the hospital emergency room is receiving the services, not paying for the services, and the private covered people, the Blue Cross or whatever plan, there is a cross-subsidization. Now that we can get into a debate over whether there is cost shifting or not, and we will.
Yeah, and I'm not sure. That I agree that private person is not paying. If they have no money and they're totally destitute, then they're not paying. But if they've chosen not to have insurance and they have means, they will pay.
Well, first, there are very few people that fit that category, and at least in terms of the hospital context. And frankly, I can tell you in terms of our bad debt, as well as the charity care, that the uninsured, a very small percentage of the uninsured are paying anything, and the only people that are paying full charges, if they even do, is the random sheik that comes from Saudi Arabia, frankly.
To part B, because it's office visit, even if it's office visit for a primary practice, for instance, that's affiliated with a hospital, it's still Part B, not Part A. So I was asking about the full price under Part B, and I just think your answer was more directed at something being done under Medicare Part A.
No, I was speaking about Part B.
Okay.
And the emergency room is almost all Part B.
Okay, we have Katie here, Bruce, and this gentleman here.
So one of the things that I think Paul mentioned on the reform early on was, maybe Lauren, I don't remember. There were several parts to it. It was the rationalizing payments. It was beneficiary liability protection. And there was also, one of you made a passing comment to providing better information to physicians about good processes of care. And it's when HCPR was created as part of this whole portfolio. And the logic at the time was, we'll do better research and we'll write down really great clinical guidelines. In the long run, the fantasy was we could even maybe tie Medicare coverage decisions to evidence-based treatment, right? That was sort of, I don't know if you remember, that was a long time ago. And that ship sailed. It didn't really play out that way. But one of the things that sort of always had sort of stymied those conversations was that the first sentence in the Medicare legislation is no part of this legislation shall be taken to say that the government's telling doctors how to practice medicine, right? Like that's the first sentence. And so every time that, in my experience watching this over 25 years, there is talk about linking payment to information about what's good clinical care or whatever, that sentence gets pulled out. It's written down, it's a real sentence. And I'm just curious if you guys have any thoughts about the importance of, could that guideline thing have made a difference? Is there some missing opportunity to provide better information? And is it ever feasible is it ever going to be feasible to link payment to information about what's quote unquote good care?
My response to that, if I follow your question, is I think, where does that information come from? How frequently is it updated? Who agrees to it? And again, with all respect, you get, physicians will start to say, no, and that you'll also get a lot of the kind of finger pointing between specialty societies because, they are not as siloed as everything is. They are not entirely. Two different specialties can be involved in. And so you can pursue those kinds of approaches, again, if I'm following your question. But again, if you can get payment to be more structured up front, whether it's a PMPM or an ACO, and I do think there are ways to overcome rural problems. I think the federal government just has to, or Medicare has to realize there will be subsidies in rural areas, and you just need to target them and pay them well, which not doing that right now, but there will be a way to get around that. And then leave the decision-making to the clinician at the point of contact, as opposed to the guidelines. If I follow your question, I think you can wrap around that with things like trying to measure on a population and outcome basis stuff you don't want to happen, like going to the hospital, like going to an emergency room. And I also think you can wrap around that and potentially, if there is absolutely clear evidence and you can have people come together and say, well, there's choosing wisely, these are low-value services, you could bring that into bear. As opposed, and it's almost like, here's a space and then you manage around the space, as opposed to I'll be in the space and you do these types of things. It's sort of the way I think about it.
I think it's partly money. I think that when AHCPR was originally formed, and I was one of the people that drafted the legislation with Peter Bedetti, which took the various agencies and put them together. I mean, we had a notion of the function, and this was one of the primary activities, and everybody remembers, I think it was the back surgeons and their initiative, and it didn't go well. And there was then an axis that formed between those kinds of people and the people that I used to work for, and a number of Republicans, and probably the current secretary, too. And over time, I'm sure he's sympathetic with that I think impeded just the funding. So that, I mean, if you look at ARC today, I mean, it's pitiful. I mean, with all due respect, it's a shell of what our aspiration was, not even a shell. And so I think part of it is that we failed over the years, not that there aren't all these measures out there, but we failed to really fund and nurture that enterprise so that it could actually support the efforts we're talking about. So I think the only salvation now is that looking into the future, that we now have all the ability to use big data in ways we never had before, and maybe the computers will solve the problem in terms of allowing us to both create the knowledge to determine what the right way to practice is, and then something that's dynamic because it can constantly readjust itself.
I'm going to stop this just so we can get these last two questions in, because if we look at the clock, we're going to run out of time, and I want to make sure we get to them. Bruce, and right here, and when we're done.
Bruce Steinwald. I'm a semi-retired health economist and a member of the Physician-Focused Payment Model Technical Advisory Committee, also known as PTAC. It took 6 months to learn how to say that. First of all, thanks for this. I mean, as someone who lived through the years that we're talking about here, I just am so pleased to be reliving those years.
Can you hold your microphone a little closer to you? Hold it.
Despite what Mark Miller said to the young people in the room, and you know how memory is selective. You don't remember the long weekends that never went anywhere. You remember the excitement of being involved in the policy process. So I want to ask a question I know is going to be addressed in the next panel, but by different people. And I think I hear both sides of an answer to the question I'm about to ask, so I wondered if you'd answer it directly. I'm not sure who to attribute this statement to. You have to fix the physician fee schedule before you can get rid of it. But it could be Bob Berenson, it could be someone else, it could be somebody on the panel, I don't know. But in any case, I think I hear both sides of the response to that question, and I wondered if you'd be willing to address it directly to establish a baseline for the next panel that comes forward.
And since the next panel will be talking about this, let's try to be brief so we can get our last question in.
Wasn't bothering anyone. So I guess, I mean, you know, just in terms of practicalities and getting things done and moving ahead, I think you could probably keep the underlying structure of the fee schedule with changes. I think probably what I was trying to say is that there's probably a different way to go at primary care and maybe cognitive more broadly and pay a bit differently, but still keep some of the fundamental structure of the fee schedule and then build around that this notion that we've said to each other a couple of times of can you define payment that allows flexibility within that. You know, either you're moving all the way out to managed care or even if you stay on a fee-for-service platform. That's.
And I think Barbara, you know, described how when you go to the next step, whatever the great payment in the sky is, you're still going to have a basis for it, and so we're stuck with fee-for-service. So we got to make it as accurate or market-oriented or whatever as possible, because at the end of the day, it's going to be the basis that we create the capitation or the fixed payment, you know, the payment amount from. We don't have anything else. I mean, you know, that's what we did in DRGs, and it's actually worked pretty well. I mean, it was, you know, cost basis back when we all were young.
Yeah, just to add to what Chip is saying, whether it's a matter of just for benchmarks or for shared savings, if you have distortions in the foundation, the structure you build is going to have problems.
Yeah, so my name is John Goodson. I'm a practicing primary care internist in Boston, but I'm also the chair of the Cognitive Care Alliance. We spent a lot of time talking about valuations, but we haven't really talked about service code definitions. Bill Shao identified this at the get-go. We've spent a lot of time talking about some of the differences in valuations that have evolved over time. But there's a fundamental problem with the definitions of the E&M service codes that has plagued the system from the very beginning and has not been addressed. And I'd like the members of the panel to take a moment and just think about that major problem, that there's been a huge change in what I call the topology of evaluation and management services. The reason my organization exists is because there's a common ground between all of us who practice cognitive specialties, that's primary care, and others, including rheumatology and infectious disease, et cetera, et cetera. It's not just primary care that's tanking. It's a broad range of specialty, of cognitive specialties. My father, a physician, said that he had two sons who'd gone into medicine. One was a surgeon, and one was a physician. We have two different worlds here that we're trying to merge, and I think we need to go back to some of the fundamental thinking, and we need to go back and be sure that the E&M service codes are appropriately defined and valued. Valuation is extremely important, but definition is even more fundamental.
I'll just say that, my point about having to create new codes was exactly directed to that, John. I mean, there's no question that there is a lot of work that's being done that's not captured in the current coding system. And I think that work needs to be recognized, and I think that the coding system, we need to create codes that include and value that work.
The counterpart to the need to bring the valuations of procedures up to date to reflect current technology, the counterpart in valuation management services is the need to evolve the coding to reflect changes in the practice of medicine.
Clearly, we've been talking here about both the need to make corrections in the current fee schedule, but also the challenges of the updating process. Even if we did the work and had what looked like it was much more accurately developed, over time it could again become distorted. And so those two things go hand in hand. I want to thank the panel. Can you join me in thanking